Okay, well, good evening, everyone, and welcome to the Career Skills Masterclass Understanding Company Culture with Estevan Garcia. This event is hosted by the Office of Career Services and Experiential Learning at the CUNY School of Public Health. My name is Taylor Drost, and I am the Career Skills Academy Program Manager. The Career Skills Academy is a program within the Office of Career Services and is a professional development program we offer for CUNY SPH students, which many of you here tonight are a part of, so we're happy to see you here. And before we get started, I just want to mention that we have multiple events coming up to look forward to, which can be found on the SPH events calendar or on Handshake. So next week we have our panel discussion on how to be a corporate mountain climber on Wednesday, November 13th at 6 p.m. This is moderated by Errol Pierre, the Vice President of State Programs at Health First, and the panel will feature 3 professionals with a variety of professional experience. And again, this event can be found on the SPH events calendar and on Handshake. And I can also share a link in the chat later this evening. But so with that said, I will introduce our speaker for this evening. So Dr. Garcia is board certified in general pediatrics and pediatric emergency medicine, or PEM, and has been practicing for nearly 30 years. Prior to joining Dartmouth, he served as Chief Medical Officer of the Massachusetts Department of Health and a regulatory policy and operational role with a focus on implementing and evaluating statewide behavioral health interventions. In addition to his public health and clinical experience, he held hospital and health system senior leadership positions at Cooley Dickinson Healthcare, Mass General Brigham Brookdale University Hospital Medical Center, and Hospitals Insurance Company. Esteban's academic positions include founding PEM Fellowship Director and Designated Institutional Official. He earned his medical degree from the University of Texas Southwestern Medical School in Dallas, Texas, where he also completed a general pediatric residency and pediatric emergency medicine fellowship. Additionally, he earned an MPA in healthcare management and policy from New York University and a DrPH from the CUNY School of Public Health. His dissertation focused on the impact of living in urban healthcare deserts on medical and behavioral health. So thank you for joining us this evening, and I will now turn it over to you.
Sure. Thanks so much. I'm going to just get my, if I can, my slides up here. And let's make sure that's the way we want it. And I'm on slideshow. So does that work for everybody? Yes? Okay, great.
Yes.
So thanks so much. So and thanks for being here. I know that I was just mentioning, I said today has been a difficult day for many, and so I just want to kind of make space for that and hope that you're taking care of yourselves, pluses or minuses, but certainly I know lots of emotions wrapped around the election. I'm a Chief Health and Wellness Officer at a college, so I am dealing with lots of situations on campus here in New Hampshire. So thanks so much for joining me. And again, I really appreciate the opportunity to speak with you about organizational culture. And I've got a list of questions that we can answer towards the end. I've just a handful really of slides to go through. And I also want to acknowledge that I am one of the older School of Public Health. So it actually started at the grad center, and so I was one of the first doctoral students. I think I was in the second cohort. I started in 2008. And I was working as an adult with family and children and a job, and then at the School of Public Health, and spent quite a bit of time working through working on my dissertation. I really enjoyed the classwork, and then when I went off to have to do my own work on my own writing, right, and work on the actual dissertation itself, that took me a long time. I was a student for 10 years. So anything less than that, you guys are doing great. So anyway, so I'll start really just with going through some organizations that I've been a part of, and I think it'll be helpful to get a sense about just a little bit about those organizations and what the cultural kind of dynamics were when I got there. Sorry, that's very slow. So currently I'm serving as the Chief Health and Wellness Officer at Dartmouth. This is a position that I've had only since March of 24, so relatively new. And for me, kind of when you think about it from a culture perspective, I'm new to higher ed. This is a new role at the college and really at many colleges and universities. What's unique about Dartmouth in this role is that the role reports directly to the college president. So I sit on a senior team, and that I think is also important. In many organizations, this role reports either through student affairs or student life, or through the provost's office. So this is different. And in this role, I have campus-wide oversight of health and wellness. So it includes things like the Student Health Center, looking at student health, including counseling, but as well as primary care, the Student Wellness Center. I also have equal access and the Title IX department roll up under me. We have a new department that's time away for medical reasons. That is also part of under my portfolio. I have the Dartmouth EMS for campus, so it's emergency medical services. And the faculty and staff wellness fall a much lower percentage of the work that I'm doing. My role was predominantly brought to really engage with students, but there was no one who was working on our faculty and staff wellness and healthcare. And so that's something that also does report up to me. This position was developed out of a commitment to care, which is our strategic plan. If you're interested, that's something you can look at. And it was about 250 stakeholders over the course of almost a year. And this was post-pandemic, so like 22, 23. There were significant issues on campus that led to the belief that and the desire to commit to health and well-being. That's the commitment to care, and to bring somebody in that would be able to focus on this work, specifically because during the pandemic we had several student suicides, which again is very unfortunate and not so uncommon in higher education. So it was an opportunity to really engage in that work as well. And so we're developing a grief support plan now, and we've had some grief support services. So this is something, when I got to campus, I realized we were still dealing with a lot of grief, and we've had many issues on campus, including protests at the beginning of May with arrests for Gaza and situations that were happening there. We additionally had a student suicide, a graduate student suicide during the summer, and an accidental drowning this summer as well. All of this is publicly reported, and we've managed to work ourselves through that. But these are all issues that developed on campus, and so we really are looking at how do we manage the grief of our students, faculty, and staff on campus? How do we support them? And then I'm also doing a centralized campus behavioral risk assessment program. So this is where we would, if somebody poses a risk to themselves or others, it's a way for the campus to know how we can be helpful, but at the same time make sure that they are safe and that the campus is safe. So that's work that I'm doing. And it's not just for students, it would include faculty and staff as well. We have about 6,500 students at Dartmouth, 4,500 are undergraduate. We have 4 professional and graduate schools. In addition to that, there are about 3,000 full-time faculty and staff members on campus. Sorry, let's see if this will get me to the next one. Just a little bit more about me. So from my education perspective, I'm old. I've been practicing medicine for almost 30 years. I have a bachelor's from Austin College, a small liberal arts school in Texas. My medical degree was from UT Southwestern in Dallas, and I went. My joke is I go to school a lot. I'm not now, and I'm really happy about that. But I have an MPA from NYU. This was an effort to really learn more about healthcare management and policy as I was becoming more active in administrative roles within hospitals. And then my degree from CUNY in 2018. My training background is in pediatric emergency medicine. So to do what I do after medical school, it was 6 years of training. So it's 3 years as a general pediatric resident and then 3 years as a pediatric emergency medicine fellow. And so, but during, you know, the plus side is when you're in these trainings, you actually start making, you know, a salary, which is not necessarily a high salary, but at least you're not borrowing anymore. So that was a real win for me. And currently my clinical work is here at Dartmouth Health. So it's a regional referral center in Lebanon, and Bay State Medical Center in Springfield, Massachusetts, where I work clinically. And I am in an emergency department taking care of kids and young adults, predominantly on the weekends. So that's my clinical work. So let's talk a little bit about organizational culture and thinking about, you know, so what is it, right? So it's a system of values, beliefs, and behavioral patterns which really drive members of the organization to make choices and their decisions. And so it's important. It's not necessarily something that you're looking at that's written out, though sometimes part of the mission, the vision, the values can be written out. But really thinking about the culture as this system that helps drive much of the choices and decisions that we make. It's how organizations do things. It's a product of compensation and incentives. So, the idea is that you can incentivize certain behaviors that you want, and organizations are able to do that. Social control system, behavioral norms, all of these are important as you think about organizational culture. It's never monolithic. It is a moving target, and it shifts over time. And we can talk a little bit more about the reason that cultures shift, and they certainly and your ability to influence culture is really important as well. So thinking about strong cultures, and so we'll talk a little bit about organizations with strong cultures and then weaker cultures. And so it's vital to enhancing the organization's performance. So this is why you want a strong culture. The idea that the common opinion towards the organization, it's commonly held, right? It's a belief that's held. There's shared values and goals across the organization. Employees are involved in organizational decisions. There are ways to do that, to bring frontline staff into those conversations, and they have open and transparent communication. So these are all what we strive for in our organizations. I will say that's not been my organizational culture all the time in my work. A weak culture, there's different values and beliefs across the organization. So maybe that unit, has functions differently, sees what's important, is more competitive in the unit on this side of the building, this floor versus that floor. The central part of the organization that's maybe housed here versus other branches of the organization that are housed other places. And if you don't have a shared belief, then it is going to be a weaker culture, because there'll be some competition potentially. Individuals work against each other and against management priorities. It's challenging to identify values of the organization. And, unlike the transparent communication and really engaged communication, this is poor communication, or really, really muddy, difficult to understand kind of who's in charge and what are we working on together? What's our goal? So I thought I would just touch on a couple of my organizations that have really that I've worked at and have been very different from a culture perspective. I have had and have worked at community nonprofit hospitals. It's important to understand that the focus is often on community, and these are nonprofit or not-for-profit hospitals, right? So I don't know if you know what's going on in Massachusetts, but there was a for-profit hospital system, the Stewart system in Massachusetts, that has had significant financial difficulties and had to, they were closing several of the hospitals. And it was very unsafe for them to do that. The system in Massachusetts, the hospital system, is overwhelmed with patients, very similar to much of what happens in New York. And so the state had to step in to prop up a couple of the hospitals, to demand that they sold some of the hospitals, and it was very difficult. So your community nonprofit hospitals really don't have shareholders, don't have profits. The community around the hospital is who the hospital is there for, and that's what the focus is. Some of the hospitals I worked at had academic portfolios, so they either had an affiliation affiliation with a medical school potentially, or they had their own internal. I was at Maimonides for a long time in Brooklyn, and from 2004 to 2012, 13, and we had our own training programs, and that's where I was the training the fellowship director. I've worked for state government. There, what sticks out to me, lots of bureaucracy, right? That's where it comes from. Multiple layers of decision making, lots of folks involved. But they're very mission driven. I mean, anybody that worked for the Department of Public Health could tell you that. But we had also some limited decision making abilities on our part. Even being pretty high up in state government, we had limited decision making because a lot of it was top down from the governor's office. And then higher ed. So higher ed is very different for me. It's I've been in higher ed. I've not been a part of the administrative apparatus, and that's my role now. Consensus driven, student focused, and then I'm dealing with protests on campus, which is very different than what I've managed before. So thinking about my community hospital experience, this was my hospital in Brooklyn. I was called in, this was Brookdale, I was called in as part of a restructuring team. There was lots of discussion about closure of Brookdale at the time. This was, I think, predates when I even got there, but they had significant financial constraints, difficulties in even making payroll, and really difficult quality as well. There was significant state involvement. The Commissioner of Health at the time, Commissioner Zucker, would call and we'd chat about work that needed to happen. Why were we still, why was the quality so poor at the time? There was strong community support, including elected officials, and I will say that was a double-edged sword. I had elected officials that would stage sit-ins in my office, all kinds of things as we tried to make some changes or differences at the organization. My role there was as chief medical officer. So essentially what that means is I was the senior most physician at the hospital and in charge of all physicians and medical practice across the hospital, including all the trainees as well. And that was the designated institutional official. It meant that the trainees or the residents reported up to me. We had lots of challenges here. And I would say that for me, reputation was a difficult challenge. We were a very poor graded hospital. There are national grades, either state and national safety grades, and called Leapfrog. And it's a consumer-driven rating system that gives you an A to an F. And we were, clearly in the D to F range the entire time I was there. Our finances were, we were not making payroll on our own. We needed to engage with the state to help make payroll. There was a lot of leadership turnover and challenges while I was there. I had 9 open leadership positions within departments that I had to hire for when I got there, and the quality was just terrible. And part of that is because if you've got no resources, then, even doing the best you can, no resources, no leadership, disengaged individuals of the workforce, it was very difficult to make change and to continue to do what we needed there. So kind of a difficult position, a role I held for 4 years, though, I joked that there was like dog years. That's kind of what it felt like. This was a tough 4 years. My priorities there, this was really an uncomfortable management style for me. I'm much more a consensus builder. I enjoy engagement. I support kind of a servant leader perspective. I support my team as well as I can. As an emergency room doc, I work nights and weekends for overnights for until I was probably 50. Even as a moonlighter, I still only work weekends now, which is something. These are unfavorable shifts, right? Unsavory shifts. I do them because I think it's the right thing to do and to be helpful to the people you work with. And so when I went into this setting in Brooklyn, I had to be incredibly decisive because we were hurting patients, right? And so I had to make changes very quickly, and I really didn't have time to build relationships. So from a leadership perspective, I had to act quickly. I needed to focus on patient safety. I needed to establish my clinical credibility, and this is something that you'll see over and over again in my work that I do. Building credibility is very important when you take on a leadership role, especially if you're new to that field. field, new to that organization, new to the state. I'm new in New Hampshire. That's where I am at today. I needed to explore the community support and figure out who I was going to partner with. I needed to build trust with my medical trainees, and they had been mistreated for quite some time, lowest paid in all of New York. There was a lot of work we had to do for them. I had to very quickly work to prevent closure of our training programs. So this was high on the list of possibilities because they were really unsupported from the organization. I had to hire for those 9 open positions, and then I had to terminate not an insane, a fairly significant number of individuals that were not meeting the needs of our patients. And so it was a lot of work that had to happen very quickly. And again, not the style I'm most comfortable with, but certainly needed to happen while we were there for the sake of our patients. So when I left, and I had a couple of other positions when I was in one other position when I was in New York. I worked for a hospital's insurance company for a year before we moved to Western Massachusetts. So we, after my stint at Brookdale, we decided that it was best for our family. I had really not seen my kids in 4 years. I was living and breathing, every day, every minute of the day at Brookdale. And so we ended up moving to Western Massachusetts, and I took a position as a community hospital. At a community hospital as a chief medical officer, so same kind of position, but very different in that rural, semi-rural, and relatively well insured, but still losing money, significant amounts of money over the course of the last several years. They lost about $20 million the year that I came into in July. The fiscal year expires or closes out in September, and we start a new fiscal year in October. And I came into that role with a year where we had a $20 million loss for a small community hospital, very different than kind of my Brookdale experience. Though we were losing money there as well, it was the numbers, just the scale was so different, right? There was significant turnover in senior staff. So this goes to our kind of culture question. I got there had been nobody as a chief medical officer, which really is a requirement for hospitals for 6 months. So, my joke was that not only was there not a chair at the table, they had essentially put the chair out in the hallway. And so I needed to come in and, sit on the table till somebody found me a chair, and then move them all over, and say, you got to have a clinical voice at the table. This is why you hired me. They had significant turnover of the senior staff. 16 senior staff members had turned over in the previous 2 years. I mean, that's crazy, right? And this is all just folks who sit at the president's, with the president and in the president's office. They had been very unsuccessful in hiring providers for several years. There were several reputational hits. So unlike what happened at Brookdale, this was very much a hospital that should be doing better than they were doing, because they were in a setting where there was higher expectations, and your population you served was more knowledgeable about these reputational hits. And so this was something else that, this was from a clinical perspective we had to manage. So my priorities here were hiring, and was hiring oversight. I needed to really take over the hiring process at the organization, and make sure from a provider perspective that I was able to bring providers on board. We had program expansion, new programs that we weren't meeting the needs of our community. Small rural community hospitals should meet the needs of their community. And then again, building credibility, right? That street cred, people understanding that I was new to the community. I speak fairly quickly. Everybody says it's because it's my New York, I don't think so. I think it's because it's my emergency department kind of background that I run around so quickly. I'm just trying to get a word in edgewise sometimes. But that was part of, I had to really build that credibility. And because there had been so much turnover on the senior team, there was concern that I would, you're just going to leave like everybody else, right? Because a lot of the roles have been interim. That's another red flag for folks that we can talk a little bit about, is when there's significant interim leadership, that's telling you there's some concerns going on. And then state government. So, we're recovering from the COVID-19 pandemic, and I came in 22. So we had been through the worst part of the pandemic, but we were the state government, the Department of Public Health had been very involved in the work at the state level to manage the pandemic. I actually relied on them as a community hospital chief medical officer to help me with, vaccines and all kinds of engagements and things that we needed to do. We had multiple calls with the state, and they were leading the work we were doing and supporting us. And then I went to them to work with them, and that became, as the chief medical officer for the state, that became a real challenge because people were exhausted, right? And so there was an interim commissioner. The commissioner, after a couple of years, had left. She was a physician. The interim commissioner was an attorney. She wanted a physician on the team. That's the position that I took. State salaries, especially if you're at state government, about a third less than what I was making in private sector. There was a lot of commuting, so I had to go. I was in Western Mass in Amherst, about 90 miles west of Boston, and our work was in Boston. Even though we said, you can telecommute and you could, but you still needed to be in Boston at least 2 days a week. It was very challenging to do that driving all the time. And my priorities there were the public health hospital. So even though I thought, I'm going to get to do public health finally, and much of what we do in hospital administration and the work I do anyway is a little public healthy, right? Not exactly what the work that public health practitioners do, but I felt like we had 4 public health hospitals, and this was kind of an area that I felt pretty comfortable with, but I needed to address our use of consultants because at the state, if you can't hire because the salaries are so low, then you hire a consultant, and then you're just paying them twice as much as you would pay if you just hired somebody for a normal rate. So this was a real problem. I needed to work on that, and we had significant challenges. These hospitals were behavioral health. We had highest level sex offender hospitals. These were people incarcerated, so there was a lot of correctional health. So these are tough places. But everybody at the state, and especially the folks that don't have any other hospital to go to, deserve safe quality care. And so that was my role at the state. I did a lot of work around vaccine equity. And so as we started to roll out our vaccines, our COVID vaccines, we understood that there were significant challenges in our disproportionately affected communities of color to engage and to make sure that we were bringing them up to the same level of vaccine availability and equity and uptake as our traditional higher neighborhoods, so traditional Boston neighborhoods and those as opposed to some of these other rural communities, and we really needed to engage them. Additionally, I'm a pediatrician, so I brought a pediatric focus. A couple of years back, there was a huge issue with RSV, respiratory syncytial virus, came in after the pandemic and really took over hospitals and emergency departments, and we were running out of ways to keep kids supported. There was no hospital bed, so we developed a whole pediatric surge work as well. And then here again, I came in as a clinician. I have a degree. I've never practiced public health as a practitioner, but I have a degree and I'm a clinician. So I needed to build public health credibility, and that took some time in state government, and it was a position that I only held for about a little over two plus years. I very much enjoyed it, but a lot of the negatives of trying to get to Boston were really difficult in that role. And then now where I'm at, so we have, the role was developed because of a history of several student deaths from suicide. We had a new president who joined just over a year ago. I've been there for now 8 months. The Commitment to Care, which is our strategic plan for health and well-being, has 73 deliverables that were due to be delivered in the first year. We just completed our first year. I've only been here 8 months, so I can tell you that not all 73 were delivered, and some are still in the works. We have multiple campus protests. I got to campus in March. May 1st was a significant protest, and that resulted in some campus arrests, lots of distraught students, family, alumni, lots of situations that we were dealing with. My priorities really were to build out my team. So, I call it the health and wellness, I'm the chief health and wellness officer, and it's the office of health and wellness, or the health and wellness office, but there's really no office, there's myself. off, right? So I'm still building out. I have a project manager that I'm trying to hire for. Tomorrow I'm doing virtual interviews all day. I've got to get somebody that can help manage projects across campus that are predominantly these deliverables. Is really some work we still need to do. That's taken me a little bit longer because we're in the middle of nowhere in New Hampshire. And so, hiring housing is very difficult here. I know I'm talking New York, but you would think that in the middle of no place, you could just build a house. It doesn't happen. And very difficult for us to find housing. It took me several months to even find, to get a campus apartment that I could use. Really establishing trust with this community. And then I'm going back to the street cred. I'm new to higher ed, right? I'm a physician sitting in the senior most, an Ivy League senior most team, and where they're discussing things that I'm still trying to figure out what we're talking about, right? College of Arts and Sciences and a bunch of things that I find very interesting, and trying to make sure. And I have to say, I had a little bit of imposter syndrome when I started. I was like, what was I thinking? I'm about as far away from Ivy League as they come. And it was, for me, I think a lot of this was understanding that what I bring to the table is my expertise, is my clinical expertise. It's also my public health expertise. And the reason that and when I've spoken with the president, the reason that she believes I was the right person for this role was because of my public health background, because they didn't need, for mental health, they didn't need a psychiatrist, that we have psychiatrists to do the clinical work. They needed someone to look at kind of the campus and really diagnose what was needed, and then engage in a way with looking at preventative and public health measures to help make things safer on campus. Do an environmental scan. We had a drowning this summer, so let's look at this from an environmental perspective and say, how do we prevent harm to students? What are things we can do to be redundant in reducing risk to students? So it's really the public health education that I think I brought to, and really that's why I ended up in the position that I have. So thank you. So that was kind of a quick way to cover where we are today, where I am today. And I am happy we can open it up for questions. I'm going to stop sharing so we can all get back on the same screen. I have a list of questions that I'm happy to take, that I'm happy to start on. And then if there are ideas or questions that others have, I think we also probably have some chat as well. And if that's, we're willing to do that. So I'll start with one of my first questions, but then if anybody wants to come off mute and ask, that's great. How could I assess company culture before I get hired? So I think this is really, this is important. And as part of the work that I've done looking at, because I've had, several positions in different industries, I think that one of the things I do first is I look online. I mean, I know it's kind of silly, but I want to know what is important. What is the company saying? If it's a hospital, they're going to have mission, vision, and values. If it's the Department of Public Health talks about their mission, vision, and values. Same thing for Dartmouth College. We have our mission, vision, and values. And so I think it's important for us to understand that is part of how how I start to examine, is this something that I think what do I bring to the table? Do I align with these mission, with the mission, the vision, and the values here? I think during the interview process, I think it's important during the interview, if you have an interview, to ask some questions, to ask, what are you looking for in this role? Tell me, give me some examples of what your organizational culture is. And I think that's really important. I looked at a public health position in Boston before going to work for the state. And one of I interviewed, this was the Boston Public Health Commission. I interviewed with 250 employees. And it was a Zoom. It was because it was a fairly significant, a high level position at the organization. And that was something that, it caught me off guard. I had no idea that it was going to be as many individuals as it was. And anybody, they had questions that people had put in initially, but they could also raise their hand and ask questions. And, I felt like my concerns about that were that I don't think I was prepared. I feel like I did okay. I got offered the job, but it was very much a challenge. And I felt like I would never do that to somebody. I would never say, oh, by the way, we didn't tell you, but you're going to be interviewing with 250 250 individuals, some people sitting at home making dinner. I mean, there was all kinds of things. And I thought this was really very strange. But I think I understood why they did that. I just wanted more transparency in the discussion about what we were going to be doing. They did it because they wanted the frontline staff to be engaged and to know who was applying for the positions. So I totally get it, and I respect that. It would have made more sense for me anyway, to know, yeah, you're going to be seeing a lot of faces on the camera, and they're going to be asking you lots of questions. So I think, and then when you're interviewing or when you go to do a visit, I think doing observations is really important. And you want to understand, just as you walk around, take the time to ask questions. If you have an opportunity where you're interviewing and you can ask your own questions, develop those questions ahead of time. Always have questions for the interviewers, right? It's really important, and because not only does it help for them to know that you've thought about enough to ask questions and you're that interested in the organization, but also because you do want that information before you were to accept a position potentially that's not a good fit for you. So I think it's important to do your homework before you get to those and applying to organizations. Get as much information as you can. If there's options to have an optional interview or to spend an afternoon, then I would say do that, because it's really important before you take one of those positions. So I think that's important. There's a question about how did I get into the state public health position. So I'll be honest, I mean, I applied for the role. I saw that it was advertised. I thought, I finally want to do more in public health. I've been a hospital administrator. I've made it through 4 years, 2 years of COVID, 2 years directing a hospital, really managing COVID for Western Mass, right? It was my role. The five colleges here, Smith, UMass, Amherst College, and Mount Holyoke, and others. I did the work. It was great work, but it wasn't what I felt like was my public health calling. And I really felt like I wanted to get in and work with those disadvantaged communities and do some of that work. And that's what they were looking for in the role. But, again, like I said, I interviewed for a different position while I was interviewing and applying for that position. So I'm a fan of having, looking for a job when I have a job, right? And making sure that I get to be the one who's driving that discussion, those questions. And if it's not a good fit, I'll know early, and then I'm not gonna worry about it. I had a couple of options when I was looking at the Dartmouth position. I was looking at another position that was more kind of back to my traditional hospital administration. It was going to be, and I thought that there was some real significant culture concerns I had when I went on site to interview, and I felt like that probably wasn't going to be a good fit for me. So again, you want to know that, and you want to ask those questions, and you want to be transparent that you're just trying to make a good decision for them and for yourself. So that's important. And oftentimes to get the right job, you do have to apply, for multiple jobs, and then figure out what it is that you really want. And you could be surprised that and even my job in Western Mass, when I was looking at that position, I wasn't convinced that I necessarily wanted it. I was like, I'm leaving Brooklyn. I really like Brooklyn. I don't know if I want to do this. And so we went and we spent some time. My spouse and daughter went. I thought it was the right move, but I said, you guys, we're all going to be moving here. We had two sons and our daughter, and I said, so you guys all got to go and figure out if this is going to be a good fit or not. And my daughter was a gymnast at the time, and I said, you have veto power, because like you really are going into gymnastics. You've been doing it for 13 years. Find out if there's a gym for you. Find out if, so looking at other, not just the job and the culture of the job, but the culture of where you're moving to is really important as well. And so you want to engage your family, or unless you're doing the move alone, then it's sometimes easier and not having to go through that. But I think that's really important. So, I think the idea, how can you determine if the culture of the company's culture is a good fit for you during the interview process? So again, I think it's, the idea that you ask those questions, you engage, you want to know, what level of interview interviewee, right, of employee are you engaging with? I will say the benefit of that 250 people was it was anybody who had, 45 minutes to jump on the Zoom, and it was of all walks of life at that organization. And so there's something to be said about an organization that does that says we want the frontline staff to also participate in interviewing and having a voice at the table. I think is really important. I think I certainly think that's important. There's a couple of how can you navigate a situation where the company culture doesn't align with kind of your individual team culture? So this is interesting, and I appreciate it. It can be, because cultures change over time, they're not, as I will say, as the leader changes of culture of a company, the culture can often change. And this is something that I think I certainly went through. So when I left Cooley Dickinson, I went in, there was a lot of, this is at Western Mass Hospital, there was a lot of challenge, a lot of turnover, so it took a while to get into a groove, to be comfortable. I knew what I was going in to do. I was able to do that. I had good partnerships with my chief nursing officer and with others on the senior team, not with all of them, but with some, enough to for us to be able to make the changes I felt we needed to. I made quality improvements with my team while I was there. But what became evident was when the CEO left, and in healthcare, hospital CEOs, 3 to 5 years is about the normal life expectancy of a hospital CEO. So if you're hitting 5 years and you're not ready to retire, you're probably looking for a different position or looking to move on. So our CEO left, and then an interim came in, and then a completely different CEO who I could not work for, right? And that's why I left and went to the state. It was my option of saying, this is really, I don't align here. We're not, I'm going to try to do the best I can. But if we don't align, I'm going to need to take care of myself and take care of my team if I can. Oftentimes, as long as you're meeting whatever the deliverables are for the organization, as long as we're rowing in the same direction, you can manage your team in a way that is appropriate for you and them, right? I am not a micromanager. When I am micromanaged, that is difficult for me. I can do it, but it doesn't mean that I'm going to micromanage my team. That is not something that's just not who I am. Now, I will have, individuals who will say, and I'm open this way, and I've told them, let me know what you need, right? And so when we do evaluations, or I've had, how can you be successful in a new role, is to ask for that feedback. And I have folks that I'm hiring all the time ask me, I want more feedback. I get it. You're a hands-off kind of guy. As long as I'm delivering what you need me to deliver, you don't need to know my daily, whatever's going on. That being said, I need more, right? I'm new, I'm right out of grad school, I want more, and then we develop that. And so I think you can individualize that with your team, but as long as you're able to manage and meet the expectations of the organization, what your team does, I think it can be different. And there is that individual team component that and most organizations and most bosses will allow you to work with your team as is efficient for you and your team and effective, as long as you're understanding what the culture is and what you're delivering on. So I think that's important as well. Okay, so I'm going to just read a couple of these questions, and we'll say see if there's opportunity here. So based on your experience in each hospital, good and bad, what was your biggest takeaway from each? Thank you. I would say that I think the difference for me for hospitals is that the understanding what's important externally. So that kind of the idea that when I went into Brookdale, there were a lot of quality concerns, but the role was very, the hospital and the leadership was influenced significantly by the state. So understand, because in general, that doesn't happen, right? So when I was at Maimonides, the state wasn't involved in our care. We had very good care. We were doing the work we were supposed to be doing. We were meeting, barely breaking even, but breaking even. Hospital medicine is always a money loser in many ways. But we were able to do a lot of that without there being a significant influence and engagement from the state. I wasn't joking when I said Commissioner Zucker would call me. He'd call me and say, "So what are you doing about that central line infection issue? Like, we're paying all this money to keep you guys open. You've got to be better." And that was strange. I mean, I have to admit, it was my first, chief medical officer role. And so, of that kind of highest physician level. And so I was accountable for everything going on at the bedside. And that was, from a physician or a provider perspective. So that was a real challenge for me. And I think understanding that what are the external influences? At Maimonides, the influence was very much, I don't know if everybody knows, Maimonides is in Borough Park, traditionally a Hasidic Jewish hospital, and a lot of influence from that community. And I was new to New York. I was new, from Texas, and really understanding kind of the cultural differences that were and the expectations. But I had great partnerships with the community there, with Hatzola and many of the other organizations that help support. They've got a huge community support network there, and so I could get a lot done by partnering with the community, and I got awards from them, and really they would fundraise for our emergency department and lots of other things. So really enjoyed that, and that was an external, but it was a community-based external influence, not a governmental-based or a regulatory-based. And then when I went to Western Mass, it was the external providers so in lots of places in New York, especially in places like Brooklyn, the providers are often employed by the hospital, because it's difficult when there's a lot of government insurance to be able to make a living as an individual provider. And so I employed everybody in New York essentially, but when I left and went to Western Mass, I employed a small percentage of our providers. The vast majority were voluntary or community providers who had their own practices. And so understanding what their needs were, how do you partner with them, was really important for me as well. So that was my takeaway, was from all three, was to understand, what is it that the community needs? How do I meet their needs? And if it is regulatory, then we have to make sure we put that on fast forward if we can. How much influence does public health have on company culture, specifically in public health jobs? Yeah, I mean, I think it's interesting. I do think if they're public health related positions, and I think it's important to understand they're traditionally all working with the same goal. And the idea is that it's a very mission-driven, the work you do in public health is mission-driven. It's the reason we're in the work, right? And so I think that there's lots of influence there. Much of what organizations are doing, parts of organizations, governmental organizations, both, and remember, when I say government, it's not just state government. My role was at state government, but there's local government, there's state government, there's federal government, the CDC, all of these other positions, CDC Foundation, always hiring, lots of other positions that people might be interested in. And they have a very obvious, and they wear their mission and their pride to be public health practitioners on their sleeve, right? And so it's important to understand that in those settings, because if that's what your goal is in public health, then you will fit very nicely into those. So I think it is pretty evident in those public health organizations. Now, there's public health organizations that do consulting, and that's different, right? So if you're going to be a consultant, then often some of the work you're doing, or much of the work you're doing, is driven by that's a for-profit company. I mean, I have paid for-profit companies to come in and do, most companies are for-profit, to come in and do evaluations. I did one just recently with a small company to do an evaluation at Dartmouth. And so, what they are doing is they're meeting they are meeting my deliverables, right? They're helping me and what I asked them to do. But that corporate structure is very different than kind of that public health structure and the goals, that public health oriented goals that public health organizations have. So there are ways to you just have to figure out what makes sense to you, what you're interested in. I enjoy consulting. I've done some of it on the side. But again, it's very different. My job is to deliver on what somebody asked me to do, as opposed to the general mission of public health and how to help protect our communities at large. So I think that's important. If you had the opportunity, would you change your approach to how you tackled each challenge you faced? Oh, so back at the hospitals. I think there's a little bit of that. I have to say, there are things that I would have done differently. I think I was incredibly decisive at Brookdale because, the culture was lacking and the quality was so bad. I do think there probably could have been ways to have engaged folks. I think they saw me come in as kind of a hatchet man, right? And because that's kind of what the job was to try to make sure we were taking care of patients, and so there were some challenges there. I think I could have been more collaborative initially, both by saying, we're going to stop hurting patients immediately, but I want to partner with you to do that, as opposed to you're doing it Estevan's way, because I was told by the governor that we needed to do things differently. So I certainly think there are some opportunities there. I would have done that differently. My work at Western Mass, I think I went into it with a different mindset. And for the Department of Public Health, I have to say, I very much appreciated that the public health practitioners took me under their wing and said, we know you're a clinician. We're going to help you understand how to be a practitioner. You got a degree, but we want to show you how to do the work that we're doing. And I really do appreciate that. Finding those thought partners in the work you're doing is really important. Nobody needed Estevan to go talk to them about getting your COVID vaccine. But could I go partner with a community organization that a community trusts, right? A community serving organization. That's what was really important. Let's find out who are the trusted messengers and let's work with them. And so that I learned, and not because of something that I learned at school necessarily. I think I learned that from the practitioners who've been doing this work for a long time, and they did it through HIV, right? And so those practitioners were very good about here's how we're going to do this work for this community. We had monkeypox as an outbreak when I was at DrPH, and very much we used a lot of the same approaches that we used back in the day for HIV with the LGBTQ community, and to develop those trusted, working with trusted messengers. There was kind of muscle memory there, and to work with them on how to roll out that vaccine and how to help folks be safe. So that's kind of where we are. I really appreciate it. I'm happy to answer any questions if anybody wants to come off mute. But if not, I really appreciate you taking the time to let me ramble on a bit, and it was a lot of fun. And if anybody, I think you have my contact information, or if you want to send an email, if you have questions that way, or want to do a Zoom individually, I'm happy to do that. There's lots of, I can give you advice on public health positions if you're interested. I certainly know the Massachusetts area, if anybody's interested in that work. I don't know the Albany work or the New York City work nearly as well anymore, but I also know some of the work in up here, and there's lots of hiring in New Hampshire as well. And again, there's real opportunities, especially for new grads that are interested. So happy to help with that if that makes sense.
Yeah, thank you so much, Dr. Garcia. I can definitely share your contact information with anyone who is interested. So thank you for offering to do that.
Great.
And yeah, so if there's any last questions, anyone can raise your hand, or you can write them in the chat. But yeah, or you can follow up via email as well. But thank you again for your time.
Sure. Thank you all, and have a great rest of your night. Thanks so much.
Thank you. Same to you. Bye, everyone. Have a wonderful night.